Hi, sorry about that delay. My name is Karen Altamari Nelson, and I am the Clinical Program Coordinator with the MS Center here at UConn Health in Farmington, Connecticut. I work very closely with Dr. Imatola, and he asked me to step in for him today to give this presentation. And I'm hoping that it's a good one and you guys get something out of this. Dr. Matola has been working on this Visibly tool. With that being said, that is a tool that he has designed to help individuals, not only healthcare providers, but across the board, young adults, general population, on how to identify MS symptoms sooner. Because right now there's nothing out there that gives a individual the ability to be able to identify MS symptoms. And as we all know, MS treatment is critical as soon as you can in order to minimize disability. Our first slide here is just a general overview of MS, the progression of where we're getting to the need for the tool and how the need for the tool has come about. The economic burden of MS in the United States is increasing every year. There's direct costs and indirect costs. Direct costs for MS is about 63.5 billion to consumers, where indirect costs for non-medical costs are 21 billion. And this is only projected to increase in the year 2039 to 105.5 billion, and we're projected to have 1.1 million patients affected by MS. Not only is this costing patients and insurance companies, but you also have a lot of loss of labor from these patients, caregiver burden, homes that need to be modified. And with all these additional costs, it's becoming more and more taxing to patients and the needs of the burden of the costs. Worldwide burden, you can see from this slide, about 2 million worldwide. Over the last 40 years of MS care, we started off in 1984 with limited diagnostic capabilities. There were delays in care, and all of these things led to a natural progression of the disease, which resulted in disability being inevitable. In 2024, with technology as it's grown, we've evolved in the diagnostic criteria being more specific. There are 22 DMTs now available, and the growing demographics in the US is allowing for more accessibility to getting information. However, because there are contributing factors of lack of awareness, these growing evolution technology is still giving us the same trajectory of disability being inevitable, just like 1984. In the real world, the journey of MS in its diverse populations, there are many barriers for patients to be able to get care. In the real world, we have delays in diagnosis, there's lower education level, there's poverty, patients have less hope, symptoms aren't recognized, and progression is advanced in some cases, even at time of diagnosis, where optimally, we would like to see prompt diagnosis with rapid treatment. We have higher education. We'll have availability of everyone across the states to have education regarding what the symptoms are, which will hopefully minimize progression and cause more hope for people. Dr. Imatola has projected DMTs in the real world strategies to improve care in diverse populations with MS. I'm going to review his slides for you. There's the outline for this part of the presentation is there's intrinsic differences in clinical phenotypes and the need for early diagnosis in MS, especially in diverse populations, and the approach to therapy based on risk for progression and real-world strategies to improve awareness and delivery of care. As you can see from this slide, MS is multifactorial. You have not only the genes that set you up biologically for to be just predetermined for MS, but you have the environmental factors of obesity, smoking, Epstein-Barr virus, vitamin D, and your social determinants of health. Social determinants of health being lack of medical accessibility, transportation issues, awareness of what these symptoms are, and all of these clinical onset of symptoms are often dismissed by patients, leading to a trajectory of a delay in diagnosis and treatment, and ultimately a poor prognosis. And as you can see from this very busy slide, that people start with natural exposures and risk factors, compounded with biological onset of the disease. You have your prodromal period where symptoms start to occur that patients are often dismissed because these symptoms go away and they're often attributed to other rationales. And then you have your first clinical isolated syndrome that is usually also not particularly followed up on because, again, they often resolve themselves. And then you have a clinical course and evolution by the time they are actually diagnosed, and you're already on a pretty severe path of disability. The window of opportunity to avoid progression of MS is very narrow, and it's, time versus disability. And again, like I had stated before, a lot of the window of opportunity is missed. The clinical isolated syndromes that are first felt and experienced by the patient are dismissed and often, thought of as something else, or there's a lot of MS mimics out there that, the rationale is, that they're misdiagnosed with other things. So by the time a true diagnosis occurs, especially with people and even medical professionals that aren't aware with this early signs of MS, you already are well past your optimum window of opportunity for early treatment. And then once treatment is started, they often want to skip right to high efficacy medication to start preventing disability that has slightly already occurred. And then it's also very important for the patients to be aware, not only of what MS symptoms are, but what contributes to MS symptoms, and the vitamin D levels, smoking, obesity, and all those other contributing factors that are often ignored and patients are educated about. Early diagnosis and impact of DMT on disability is outlined in this slide. That, again, time is brain, and that the quicker that patients are treated, the quicker that disability can be minimized. And the McDonald criteria has become more not specific. It's become more easier to be applied, the McDonald criteria. The McDonald criteria was recently updated, and it leads to a quicker diagnosis. And again, this slide just, again, the impact on early diagnosis and the impact of the DMT on disability. And again, the absolute target for treatment is NEDA. You want your patients to have no new disability. You want the MRI, you want absence of new or enlarging T2 lesions or T1 gallium enhancing lesions. You want no sustained expanded disability scale progression. You want no clinical relapses, and you want to prevent atrophy. Secondary prevention is critical for changing MS trajectories. There are new biomarkers out there. Time is brain, the golden hour for MS. Patients diagnosed and treated in a reasonable time frame is currently less than 6 months. And as previously stated, this is often not the case. Patients often within that first 6 months with their first clinical isolated syndrome, they often don't even seek medical treatment. These symptoms typically resolve on their own, and the patients wait until the next time they experience a more disabling, more acute event that they will even seek medical treatment. And with social determinants of health, you might even miss that opportunity as well, because patients are unable to get to a healthcare provider. They're in a rural area. They, again, after some time, those symptoms will resolve as well. So often, even the second event or attack is often not followed up on, and again, leading to this time frame to be extended out to, I've even seen up to years. And again, time to DMT, using the analogy from time to needle. And the next slides, that just talks about induction versus escalation and the risk versus effectiveness, where you have in the next slide, we have your low efficacy meds to your high efficacy meds. And if you have time being on the timeline of when you catch the disease activity, which ones are more effective. Often the oral and injectable medications are not used as frequently, because by the time patients are being caught in their disease process, they have a high burden of disease, and symptoms are often severe, where they need to jump right to your injectables and infusible medications in order to prevent disability progression. And again, the risk factors for stratifying onset is age at diagnosis for disability, if you're African American or Hispanic ancestry, if you are a smoker or not. Your obesity is also a contributing factor. The burden of T2 lesions in locations at time of diagnosis, and if there are any spinal cord lesions or atrophy at time of diagnosis. These are dependent risk factors, or again, the delays in diagnosis, delays in DMT initiation, lack of access to MS centers. Insurance issues are becoming increasingly more often than not causing delays in start of DMTs. Comorbidities, transportation, depression are all factors that lead to patients' lack of ability to get and seek care. Again, this slide will also talks about how MS is an ongoing permanent injury that is silent. And some people will even have their first clinical isolated syndrome without even experiencing major symptoms, and these are often going unnoticed. There are multiple clinical trials that are documenting the benefits of early DMTs, and there is that window of opportunity talking about early therapy as minimizing disability and projecting a better outcome.
I think Karen might have froze. If you can hear us, Karen, you are frozen. Shoot, let's see. Okay. All right. We'll see if she can hop back on here. But in the meantime, in case we get delayed here and we want to make sure she can wrap up the talk, the future directions for 2025, just a real quick, and we can get more into this, but we are looking to hopefully secure some funding moving into the next year, and therefore are probably going to take a break for the first quarter at least, or into the summer of the beginning of the year, hopefully to find that money and move forward. But I see Karen just pop back on, but I just wanted to make that announcement in case we get caught up for time. More information will come out in the recap and that kind of stuff, but just to give the group a heads up, we're hoping to continue the program. We just want to make sure we are getting properly supported and things like that. So we will be taking a bit of a break there at the beginning of the year. But I see Karen's back on. Karen, sorry you froze there, but you're back with us. Hopefully you're able to get things back on. There we go.
All right. Sorry about that.
That's it.
I was
You're
like,
you're
oh,
a part of the Echo crew now. Every Zoom issues, that's you're part of the team now.
I made it official. Sorry about that, everyone. So, as I was saying before, I was rudely cut off. Dr. Imatola has identified 4 different populations of MS patients, and where he often matches patient subtypes and needs to their specific population of patients. He has pediatric patients that are less than 15 to 18. He has his newly diagnosed MS patients that require a lot of onboarding, education, and a lot of education on what MS is and how you move forward with it. You have your MS plus patient, which is your patient that has MS, but they also have 2 or more serious diagnoses and comorbidities, which is more your middle-aged patient population, as well as your MS and aging, which is your patients who are 60 plus, who also have different needs and different ways to manage MS. With that in mind and the different ways to manage MS patients, why am I? Okay. He talks about, the pediatric patients, how you work with pediatric colleagues and how their care is slightly more different than the care of your little older patients in their 20s and 30s versus your middle-aged patients versus your older patients. They have not only, they're a little more isolated, they have different educational needs. They usually have different psychosocial needs as well. So not only are you treating their MS and what's best and what they can manage, you also have to incorporate their other special needs based on their age population. Your newly diagnosed patient, which is across the board for most patients, pediatric and early 20s and 30s, that you have to establish their burden of disease and what their social determinants of health are, what their insurance needs and medications may be, what programs are available to them. You can get your social worker involved to help them navigate the changing work structure that they might be facing, or monetary or support from local organizations. They need a lot of education up front, and they need to be encouraged about shared decision making on what's best for them and how to move forward. And as the MS population ages, you not only are you dealing with the signs and symptoms of MS, but you're also dealing with natural aging and comorbidities and conditions. Do they have a cardiac issue? Do they have diabetes? Do they have, migraines? Do they have all of these other burdens of comorbidities that they have to also manage? And then you have a polypharmacy in this patient population, because not only are they dealing with, maybe blood pressure issues, cardiac issues, headaches, they're also dealing with other medications that other providers are prescribing for them. And polypharmacy is a very big problem in this age group. A social worker is also very important in this age, because as people are starting to think of retirement and think of, how they're moving forward later in life, they also, tend to be starting to experience a little more disability at this point, and what are their factors that they have to deal with at this aging population. And also shared decision-making on how to continue with drug modifying therapies at this stage. And then you have the aging population, you're 65 or greater. Also, polypharmacy continues to be an issue. What are their needs now that they're mostly retired? Where is their level of disability? Are we going to continue DMTs at this juncture or not? Or are we going to talk about de-escalating therapy? Dementia and delirium care is also usually a topic that the social workers are very helpful with in helping families manage the aging adult care, the caregiver burden, and what other needs they have. And then you also want to really make sure physical therapy is still part of their program, because falls at this age tend to be more severe, especially in your older patients. That can lead to more comorbidities for the patient. A tool for neurologists to use is Dr. Imatola has come up with these 4 squares for neurologists and for patients. So here's the patient portion here, and then you have your neurologist portion here. So the neurologist portion talks about, making sure the neurologist is aware of the burden of symptoms, the burden of disease activity, personal risk factors for the patient, and what the patient's educational needs are. Where on the flip side for the patient also should know their burden of symptoms. They should keep a diary. They should be aware of what symptoms they initiated with, what new symptoms they have, and keep a running diary on, so that they know if this is a new symptom from them or just a symptom that's getting worse. They also should be very aware of where their burden of disease activity is. They should be able to know where their lesions are, if there are any new lesions, how many they have any enhanced. And our patients, I know here at UConn, Dr. Imatola will pull up their MRI with each and every visit, and he will review that with them so that the patients are well aware of what they are, where their lesions are, maybe what they should be experiencing or can project to experience. The patients are aware of what their risk factors are, what they can control and what they can't control, and how they can help manage that to minimize those risk factors, and educating the patient on their preventative, not only preventative, but also how to manage and take control of their own wellness, and so that they can live their best life. So that is also, with exercise, diet, make sure that they take medications and supplements, and that they're well educated on all of those things. Which brings us to the beginning of where we started from, is Dr. Imatola has designed this Visibly tool. This tool is a bilingual tool that is English and Spanish, and it helps to identify early warning signs to the general population on what to expect and to be alerted to. Visi meaning vision changes, blurry vision, desaturation of color, changes in color, and any pain or double vision. Those are all early warning signs with the eyes. Balance, if there's any loss of balance, or any pain or abdominal pain, or abdominal or back pain will also help throw somebody off of balance. Limb numbness or weakness, that's an early warning sign, and it's usually young people that it affects. So this bilingual tool comes in a card, and it's easy to keep with you, and it also on the back of the card, it explains all of the different areas. And this camera this little QR code can also take you directly to the paper that this is associated with. And you can also download that and have more availability to this tool. But with these simple things, It would really make a huge difference in getting patients to seek medical attention if these symptoms do occur. It's funny that, in a lot of school systems and children are taught early at an early age all the signs and symptoms of stroke. They're taught at an early age all the signs and symptoms of cardiac events and, how to manage a cardiac arrest. But they're not talked about, or there's no tool out there currently until this one on how to manage symptoms that would affect children or young adults their age. They're being taught how to manage things for other people or when you get older. So I think this is an amazing tool that, would really help bring home the take-home message and to advocate for early awareness, early DMT treatment, and when to stop DMT inertia. The McDonald criteria and other diagnostic tools as soon as possible. LP puncture is also a very prognostic value to patients, and it adds a lot of benefit. And we should also make sure we address social determinants of health and consider heterogeneity, comparing different nationalities and what makes them more susceptible to MS, and special considerations to patients from other communities like LGBTQ plus communities, and what we need to do to make sure that these patients are comfortable in expressing their symptoms and concerns to the healthcare provider so that we can give them immediate treatment and care. And then we also have, then the more that our neurologists and the more that our medical professionals can have early awareness as well, can also help to bring the population to an early treatment with lack of care, well, with better care. This is the team that Dr. Imatola likes to promote, that, taking care of MMS message is not an individual, but a team approach. And then also I do have here, Dr. Imatola is also working on a pilot project for his Visibly tool, and that this is to get this out to the community, out to the public, and awareness for young people. And the purpose of this tool would be raising early awareness, facilitating early detection and treatment, improving patient outcomes, and educating the stakeholders. This would also make sure that we get this tool in the proper hands. We need to target the young people of the world. It will focus on educating high school and college students and making sure that they're aware of early MS symptoms and the importance of timely care. This is a tool that should be in every high school and every college health center with every college, so that when they go to seek care at even universities and school nurses, they should be able to say, in health classes in high school, should be able to be teaching and telling the students of the age that it affects the most how to identify these symptoms. And again, Visibly stands for, the vision disturbances common in early MS, balance and belly numbness or back pain, limb numbness and weakness, and it usually occurs in young people. The goal projection for Visibly would be youth outreach, again, to target high school and college-aged individuals to promote early awareness and detection of MS, to establish educational programs within school systems and health classes to teach the early signs and symptoms, minority populations that have limited access to healthcare, who can't readily seek pediatric or neurology care, and to aim to close the gaps in diagnosis and treatment. This tool would be vital in making that a worldwide known tool to prevent this delay in care, and to educate non-neurologists and healthcare providers and school nurses on early signs of MS so that there's a timely referral to treatment and to prevent disease progression. The summary again is the breakdown of visibly, and that this is a bilingual framework to raise awareness and facilitate early detection of multiple sclerosis. And this acronym should be as common as BFAST, or as common as MI symptoms, that all the across the country, everyone should be aware of MS early detection. The future of the visibility tool should be, again, to initiate high school and college programs to promote awareness. They should be implemented, and we should partner with schools and colleges, rural areas, primary care physicians, non-neurologists. Should be expected outcomes are to increase early awareness, to have greater access to oral DMTs, because when you have currently the way patients are diagnosed is that they are diagnosed and already with a high burden of disease, multiple symptoms, and then we have to jump immediately to high efficacy medications, which usually are your infusible, one injectable and one oral. Where if you do have early detection, especially with high school and young adults, oral medications are usually lead to more compliance and are easier to manage. And because of the delays in diagnosis, often these medications can't be used because you really want to jump to higher efficacy meds for prevention of disease progression and prevention of disability, where if we have earlier diagnosis, a lot more of these medications can be used early on to help promote compliance in the young adults. And then, we would like to continue to evaluate data collection on timelines before and after the awareness campaign, and how quickly people are being diagnosed. Are we seeing the difference across the country on patients bringing their tool in and saying, I'm having these symptoms. They've come on, and they're not being ignored or minimized, and they're actually being followed up on. And that would be also wonderful to treat patients early and to follow the adherence rate of young adults who receive early detection. So I'm sorry, this was a little choppy. But I hope that you got the take-home message that, this Visibly tool is going to be as well-renowned and as well-known as BFAST, because even though BFAST is a fabulous tool and most of the country can react quickly to the signs of stroke, that's wonderful for young adults and young children to know, but it's also to help somebody else and to know in the future what to expect for themselves, where Visibly is a tool that they can use to treat their own care in real time, that this is something that they can use to be able to detect and treat a condition that does affect young people. And that's the key here, is this is a condition that affects the young people, and they're not educated on this disease that is critical for their age group. And with this tool, hopefully that will change the trajectory of MS worldwide. Thank you. If there's any questions, do my best.
Karen, thank you very much. Really appreciate it again. Yeah, we'll open it up for questions. We can, if you want to stop your share there, Karen,
Correct.
you'll be able to see everybody a little bit better. But yeah, we'll open it up.
Well, Karen, thank you for your presentation. When I learned about Visibly, I was very impressed with it. I've been sharing it with rural providers so that more information can be out there and available, as well as community members, so folks know what to look for. And I also loved the patient subtype needs. I thought that was a great way for any physician to kind of address some of those needs of the patient. And the patient neurologist tool, where could we find that? Is that accessible? Is that something that can be included after the session?
I'm sure Dr. Matola, I know he has developed that specifically, and I believe, and I know for a fact there is a paper out there with that in there as well. Because Dr. Matola has also written many papers on the lack of knowledge of MS students, excuse me, the lack of medical students in MS care that, when often when they have to choose a subspecialty to take under their residency in different specialties, it's not, neurology is often not one chosen by many medical students. So he also made that Foursquare tool so that they would have something available to be able to access when you are assessing a neurology patient and you are suspecting MS, how to manage and ask the different questions and what you should be focusing on. So I do know that he does have a paper written out there on that, and that I will ask him how we can share that with everyone. And that he is very proud of that. And we have that in our onboarding packet as well for our patients on what they should be aware of. And that, success in managing your own MS is to know what your symptoms are, where your lesions are, what your factors that you can control to help make your symptoms less. And then the fact that, you really should be able to know education on, we on our staff specifically, we do have not only nurses, we have social workers, we have pharmacists here to help answer patient questions. Especially for the newly diagnosed, they have 1,001 questions, and in one of our presentations, we do have a slide on there. Who do you contact if you have this symptom versus this symptom? Is that an MS symptom? And we actually have a little algorithm in one of our presentations on, if you have a UTI symptom, who do you contact? If you have a new MS symptom, is it appropriate to contact your neurologist? If you have a cold, who do you contact? Because not everything is an MS symptom. So, and just that basic knowledge up front for our patients gives them a little more feeling of ease that they are being well taken care of, that they have some control. I mean, I had a patient ask me once when he was first diagnosed, can I eat sushi? And I said, do you like sushi? And he said, well, I love it. I said, well, then by all means, you can continue to eat sushi. I mean, but even something as simple as that, they really don't know once they're diagnosed what it truly means for them. So, and then with our medical students, not having as much education on the topic as well, this Visibly tool will also be a great way for them to also have the, start thinking MS, because I've heard a lot of testimony on patients who've come in and said, thinking back, I had 3 episodes of numbness in my hands or feet, and they went away within like 2 days, so I ignored it. I just thought I had, pinched something, and they ignored it. And then I've had someone say to me, oh, I had a day and a half of this weird feeling in my eye, but then it went away. So I just thought it was lack of sleep or I was getting a headache. So young people, especially who are invincible, who nothing ever touches them, if they have something that goes away, they always contribute it to being nothing, or they contribute it to another factor because they don't know there's any signs of anything that would mean something to them.
Yeah, I love that these are great resources for patients and providers alike. That's great. Thank you, Karen.
Thank you.
Anybody else have any questions or comments? You can put them in the chat if you can't unmute. If you can't unmute, just go ahead and fire away. Quiet group today. Quiet group. Well, Karen, I forgot to ask you when you were coming on to the session. Are we allowed to share his slides with the group? We typically do, but we also just want to be, mindful of that.
Sure, he wouldn't
Okay.
mind.
Okay. No, that sounds great. Well, so we'll make sure this goes out to everybody. And so if there are any follow-up questions, we can direct them to everyone. This session is also recorded, so we'll have the presentation up again as well. So,
And I just want to give a disclosure that I'm sure if
sure.
Dr. Emanuel was here to do this himself, it would have been 110% better. But with my being volunteered at the last second, I really do hope I did it justice. And the takeaway message is that, again, and I personally feel as strongly as he does about this Visibly tool, because I have young adult children, and there's often children coming in around my kids' ages that could have been treated 1 to 3 years sooner had they been aware of what they were feeling, experiencing, and had this weird phenomenon that they dismissed as a symptom that they ignored.
You did great, Karen. We can't thank you enough. It was very last minute for you, and so it was great. We appreciate it. I think what we'll do, we'll kind of segue into kind of maybe some next steps here for 2025. So, Karen, if you do have to hop off, you can, or you can stay on. But just some brief announcements. Again, while we were waiting for Karen to kind of hop back on when we had that technical glitch, we are going to be taking a break in the beginning of 2025 with the sessions, with the hope of starting them back up, summerish time frame. But we'll be in touch with more information as we're looking for future funding. In the meantime, if you have questions, if you have topic ideas, anything like that, please don't hesitate to reach out. We can still get people connected to get answers, to get resources in that time frame. Just because we don't have sessions does not mean we won't connect anybody or anything like that. So we just really want to be clear on that we're still a resource for everybody that's on this call and for the people that are on the project. So please don't hesitate to reach out. I don't know, Sarah, if there was anything else you wanted to say about that.
No, it's been a great year so far with the first session, and looking forward to the funding opportunities to continue it and to include other neurodegenerative diseases as well, to really expand the knowledge of all of those. So thank you.
Does anybody else have any questions about things kind of moving forward? Okay. If there aren't any, we will go ahead and adjourn. Be on the lookout for the information on the slides and the recording and everything. And if there are any other questions or anything like that, please let me know.
Thank you.
Thanks, everybody.
Bye.